Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 212 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, ASL, a 19-year-old male presented to the student health clinic with several days of fever, sore throat and profound fatigue. ASL has evident tonsillitis on examination and has some palpable cervical lymphadenopathy. The provider suspected possible streptococcal pharyngitis and prescribed amoxicillin. The next day he developed a pruritic, maculopapular rash. Which of the microbes listed below is the most likely cause of ASL's illness? Is it A. adenovirus? Or B. Epstein-Barr virus? Or C. human immunodeficiency virus? Or D. Mycoplasma pneumoniae? Or is it E. Streptococcus pyogenes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Epstein-Barr virus, and I will explain why. This patient most likely has infectious mononucleosis caused by Epstein-Barr virus, abbreviated as EBV. He has tonsillitis with prominent adenopathy and fatigue. Splenomegaly may also be identified on examination, and laboratory evaluation can show atypical lymphocytosis, thrombocytopenia and hepatitis. Patients with active Epstein-Barr virus infection may develop drug eruptions when prescribed penicillins. And the next question reads, TDF, a 17-year-old male presented to the student health clinic with about a week of fevers, malaise, sore throat, oral ulcers and 1 day of non-pruritic, diffuse, erythematous morbilliform rash. TDF is otherwise healthy and takes no medications. He is sexually active. On examination, TDF has non-exudative pharyngitis with stomatitis, along with palpable cervical lymphadenopathy and mild splenomegaly. The photo in the next slide represents TDF's clinical picture. Pause the video and carefully scrutinize the photo before answering the next question. In addition to testing for infectious mononucleosis, what diagnosis should you also consider? Is it A. acute HIV infection? Or B. adult Still's disease? Or C. herpes simplex virus infection? Or D. measles? Or is it E. parvovirus infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. acute HIV infection, and I will explain why. Acute HIV can present with fever, pharyngitis, lymphadenopathy and exanthematous rash, and should be considered in the differential diagnosis when a patient presents with a mononucleosis-like syndrome. Please proceed to the next question. And the next question reads, JJM, a 4-year-old girl presented with 5 days of low-grade fevers and malaise and 1 day of rash on her face and trunk. Carefully scrutinize the picture in this slide. Her pediatrician advised supportive care and the rash and fevers resolved over the next few days. JJM's 15-year-old foster brother has sickle cell disease. So my question to you is, if JJM were to have infection with the same agent, what complication would he be particularly at risk for? Would it be A. aplastic anemia, or B. gastroenteritis, or C. meningoencephalitis, or D. osteomyelitis, or would it be E. pneumonia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. aplastic anemia, and I will clarify why. In patients with hemoglobinopathies, parvovirus can cause pure red cell aplasia by driving persistent lysis of red blood cell precursors. Pregnant women are also particularly at risk for severe complications with parvovirus infection, including miscarriage, intrauterine fetal death and hydrops fetalis. Please progress to the next question. And the next question reads, TBT, a 14-year-old male with no past medical history presented to his pediatrician with a few days of a papillovaesicular rash, low-grade fevers, pharyngitis and malaise. The first skin lesions were noted on TBT's head and trunk, and then he developed a diffuse exanthem. Carefully scrutinize the photos in the next slide before answering the question. Pause the video and carefully scrutinize these photos before attempting to answer the question in the next slide. Reactivation of latent infection with this virus can be associated with all of the following, except A. Fitzhugh-Curtis syndrome, or B. Hutchinson's sign, or C. postherpetic neuralgia, or D. Ramsay-Hunt syndrome, or is it E. zoster ophthalmicus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Fitzhugh-Curtis syndrome, and I will explain why. TBT likely has chickenpox, caused by varicella zoster virus. Fitzhugh-Curtis syndrome is adhesive hepatic capsulitis, and is a complication of pelvic inflammatory disease, most commonly caused by gonorrhea or chlamydia. Ramsay-Hunt syndrome is reactivation of VZV from the geniculate ganglion, and typically manifests as vesicles in the ear, associated at times with unilateral facial paresis and taste disturbance on the anterior 2/3 of the tongue. Hutchinson's sign, which is the appearance of vesicular lesions on the tip of the nose, is a manifestation of zoster ophthalmicus, and reflects viral reactivation down the nasociliary branch of the trigeminal nerve. Postherpetic neuralgia is a common complication of reactivation of VZV. Please proceed to the next question. And the next question reads, SFC, a 4-year-old girl presented to her pediatrician's office with painful ulcerative lesions on her tongue, lips and hands. SFC's mother says that she started feeling ill about 1 to 2 days before the sores were noticed, and had significant fatigue, low-grade fevers and cough. Carefully scrutinize the photo in the next slide before attempting to answer the question below. So my question to you is, what is the best treatment recommendation? Is it A. acyclovir, or B. amoxicillin, or C. clindamycin, or D. corticosteroids, or is it E. supportive care? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Supportive care, and I will explain why. This patient likely has hand, foot and mouth disease, which is typically caused by enteroviridae, most commonly Coxsackie A16. The illness is usually mild and self-limited. Analgesics may be helpful for symptomatic relief. Please proceed to the next question. And the next question reads, SPS, a 17-year-old girl presented with fever and redness and swelling of her leg after falling off her bike and scraping her knee. SPS initially just had some bruising on her knee, but then started to notice red streaks extending from that area, and up her thigh. SPS also started having nausea and vomiting and diffuse muscle aches. She presented to the emergency department later that day. On examination, SPS's temperature was 39.4 degrees Celsius. Her heart rate was 124 beats per minute, and she had a blood pressure of 80 systolic 40 diastolic. The area of erythema on SPS's thigh expanded rapidly over the next few hours. A swab from her knee wound recovered gram-positive cocci. So my question to you is, which of the microorganisms listed below is most likely to be the cause of SPS's symptoms? Is it A. Enterococcus fischum, or B. Staphylococcus lugdunensis, or C. Streptococcus agalactiae, or D. Streptococcus pneumoniae, or is it E. Streptococcus pyogenes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Streptococcus pyogenes. And I will clarify why. SPS has rapidly progressive cellulitis with evident lymphangitis, and some findings concerning for possible developing toxic shock syndrome, which is most often caused by group A streptococcal infection. She requires antibiotic therapy including, if possible, antibiotics that can suppress toxin production, and also surgical consultation to assess the need for debridement. Please proceed to the next question. And the next question reads, TPO, a 42-year-old man presented to his primary care physician with 4 days of mildly pruritic rash, predominantly around his groin, and on his legs. He was otherwise feeling well. On exam, TPO was noted to have multiple punctate areas of erythema, surrounding hair follicles in his groin and on both legs. TPO had no palmoplantar lesions. He also mentioned that he had spent several hours in his hot tub the week before he noticed the rash. Carefully scrutinize the photo in this slide before answering the question below. So my question to you is, what is the most likely cause of TPO's folliculitis? Is it A. Candida albicans, or B. methicillin-resistant Staphylococcus aureus, or C. Mycobacterium avium complex, or D. Pseudomonas aeruginosa, or is it E. Streptococcus pyogenes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Pseudomonas aeruginosa. I will explain why. This patient likely has hot tub folliculitis, which is most commonly caused by Pseudomonas aeruginosa. This infection is usually self-limited and does not require systemic antibiotic therapy. Please advance to the next question. And the next question reads, CMO, a 55-year-old man presented with a 3-month history of progressive erythematous nodules on his hand and forearm. He fishes frequently, and remembers puncturing his finger with a fishhook about 2 months ago. The puncture wound healed well initially, but then CMO developed an erythematous nodule at the puncture site. CMO later noticed two new nodules on the dorsum of his hand, proximal to the initial injury. CMO now has another new nodule that just developed on his forearm. So my question to you is, what is the most likely cause of CMO's infection? Is it A. Erysipelophthirix ruseopathiae, or B. Leishmania brasiliensis, or C. Mycobacterium marinum, or D. Nocardia asteroides, or is it E. Vibrio vulnificus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Mycobacterium marinum. I will clarify why. CMO had an aquatic inoculation injury to his hand and then developed nodular lesions with proximal sporotrichoid spread. He most likely developed infection with Mycobacterium marinum. Please progress to the next question. And the next question reads, PSI, a 6-year-old girl was brought to her pediatrician's office by her mother because of fevers and painful swelling in her left axilla. PSI has been feeling unwell for a few weeks and her mother has recorded intermittent fevers with temperatures over 38.3 degrees Celsius. On examination, PSI has a firm nodule in her left axilla without overlying skin changes and without appreciable fluctuance. They have a young kitten at home and PSI's mother says the girl did have a minor scratch wound several weeks ago, but it healed well and she was treated only with topical antibacterials. So my question to you is, antibiotics with activity against the organism causing PSI's infection include all of the following, except A. azithromycin, or B. ceftriaxone, or C. ciprofloxacin, or D. rifampin, or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. vancomycin. I will clarify why. PSI likely has cat scratch disease, caused by Bartonella henselae. It is typically self-limited, but in cases of severe disease or complicated infections, including endocarditis, retinitis, bacillary angiomatosis, etc., antibiotics are recommended. Vancomycin is not active against this gram-negative bacillus. Please proceed to the next question. And the next question reads, SKS, a 23-year-old shepherd presented with a progressive ulceronodular lesion on his hand. SKS said he originally developed the wound after sustaining a scratch on his hand while slaughtering a sheep. SKS developed a small papule at the site, which then blistered and ulcerated. The area of ulceration has a black eschar but minimal surrounding cellulitis. Carefully scrutinize the photo in this slide before answering the question below. So my question to you is, which of the following is not a virulence factor for this microorganism? Is it A. botulinum toxin, or B. edema factor, or C. lethal factor, or D. polypeptide capsule, or is it E. protective antigen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. botulinum toxin. I will explain why. The two main virulence factors for Bacillus anthracis are the polypeptide capsule and the toxin complex. The toxin complex is comprised of LF, EF and PA. EF increases CAMP, which leads to impaired cellular water homeostasis and inhibits macrophage and neutrophil function. LF is a zinc-dependent metalloproteinase that disturbs intracellular signaling pathways in a variety of cell types and results in death or decreased function of macrophages, lymphocytes, dendritic cells, neutrophils and endothelial cells. Please proceed to the next question. And the next question reads, JWW, a patient presents to the emergency department with a painful left hand after being bitten by a cat. JWW has a deep puncture wound with some purulent drainage and surrounding cellulitis. Wound cultures are taken and JWW is given broad-spectrum antibiotics and tetanus vaccination. So my question to you is, what bacterium is the most likely cause of JWW's infection? Is it A. Capnocytophagia canamorsis, or B. Eikenella corrodens, or C. Erysipelophryx ruseopathiae, or D. Pasteurella multocida, or is it E. Pseudomonas aeruginosa? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Pasteurella multocida. I will clarify why. Gram-negative anaerobes, including Pasteurella, are commonly associated with both cat and dog bites. Please progress to the next question. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 213.